This is one of the first robotic arthroplasty in an ankylosed knee. We have nothing to disclose. This young patient came to us with polyarthritis. She was suffering from rheumatoid arthritis, for which she was taking disease modifying anti-rheumatic drugs for the last 10 years. In the last 5 years, her joint pains had worsened, especially in her knees, and the left knee was kind of stiff and painful, and the right knee had a deformity with about 10 degrees of valgus deformity, and her day-to-day activities were affected because of this pain in both the knees and deformity. When she came to us, we had offered her the possibility of a total knee replacement, both the sides, and also explained to her regarding the difficulty of taking down a fused knee. We took X-ray radiographs and showed that the right knee had a severe arthritis and the left knee had fused in about 30 degrees of flexion, and it was a bony fusion what she had in both the X-ray and CT scans. She was the kind of shuffling gait, and the pain in both the knees was making her life difficult. So she was willing for knee replacement, and we planned for a robotic knee replacement. Our robot is a CT scan based robot where we take the CT scans and then try to segment the bone with the help of a macro product specialist. So we had a tough time segmenting the bone on the left side in order to get the anatomical plane through which we can do a joint replacement surgery. So we had, since we were planning for a bilateral knee replacement, we had both the knee sizes, and we had an idea of what the sizes are going to be. So once the segmentation is over, we found out that she had bony fusion in certain areas, and some of the areas were relatively free, and we could take our bony registrations in that area. So once we planned, we looked to get the resections exactly as how we would do in a mechanical alignment scenario, where we were looking at a 0-degree mechanical alignment with the cuts according to the thickness of the implants. We were planning for a posterior stabilized knee for both the sides. Intraoperatively, when we checked the knee under anesthesia, again we found it was stiff without any movement, especially on the left side, and it confirmed the bony ankylosis which we had seen. We went by a standard midline incision with a medial parapatellar arthrotomy, and we found the patella was stuck to the anterior femur, which we had to release. And once we released the patella, we could see a bit of the joint line where the uninvolved area of the femur and tibia could be seen, and the joint line could be determined. We did a freehand osteotomy of the fusion, and once that fusion was taken down, the knee could be bent easily. We went on to do the bony registrations in order to feed the bony landmarks with the CT scan data which we already had in the robot. So once we made sure that the bony landmarks were taken from those areas which were not involved and not through the osteotomy site, so the relatively normal kind of areas were taken down in bony registrations, and then we could get a reasonable good bony registration. So once we were happy with the registration, we started preparing the bone. This was the distal femoral cut which we had taken, and then we went on to take the proximal tibial cut appropriate to the thickness of the minimum thickness of the implant. So once we had taken these bony preparations, we checked for the ligament laxity, and we were reasonably happy to see that the collateral ligaments were intact and could be balanced reasonably well. The rest of the cuts followed, like the anterior femoral cut and the anterior chamfer cut, the posterior femoral posterior condyle cuts and also the posterior chamfer cuts. So the bone was very osteoporotic, as expected in a rheumatoid arthritis, but reasonably good to fix the implant. And we could also look at the bony, the balance of the ligaments with the spacer block, and found that the ligaments were reasonably balanced in extension, and also in the same way we checked the flexion balance and found they were also equally good. If at all the flexion deformity had persisted, we would make a recut. The bit of laxity was noted on the medial side, so we had kept a backup of constrained liners if needed. And with the trial we could see that we could get a reasonable good range of flexion. The post-op x-ray on the right side, we could do a standard PS design, and it was reasonably stable, straightforward total knee replacement. On the left side we used a universal tibial tray, which was a semi-constrained implant because of the bit laxity on the medial side, which we could feel intraoperatively. So on day 1 we start the rehabilitation after the surgery. Because of the muscle weakness, she had difficulty in full flexion initially. Even though on table we could attain full flexion, we mobilized the patient with braces protection so that the muscle weakness and the osteoporotic bone would not cause harm to the patient with the physio mobilization. 6 weeks down the line, she was much better as far as pain is concerned, and she was walking without support, and she was doing her level best to get her knee range of motion and muscle strength back. So that was at 6 weeks, which is the first follow-up we call, looking at the knee ROM and also how well they are doing the exercise. When she came to us currently 4 years down the line, she was much better, and she was very happy with the results. So in conclusion, we would like to say that ankylosis knee is a difficult job, and a robotic total knee replacement did help us to get a good implant with a good sized implant in a well balanced manner in the knee, and the good results. Thank you.